Thank you, Samuel. So this is a summary for all of you that we have heard today. Most of the things. The first thing is, above all, in every surgery, that your team knows your setup. That you're not desperate at 8 o'clock in the morning just trying to find something. And to be hungry, you must be calm. A steady state. Just you use whatever you want the position, but check motion before doing the surgery, and your instruments you can simulate before the surgery that you are not going to touch the table or something like that. Define the landmarks and palpate ulnar nerve. Just confirming that the ulnar nerve does not subluxate during elbow motion and trying to find before the surgery where is this nerve. Distend elbow joint prior to initial portal placement. Increase the distance of the nerves and artery from the portal site. And you use, most of the time, myself I use that, soft spot posteriorly. Know all the portals. I have seen here many new techniques, but utilize proximal anterior portals when possible. So the scope, the safest portal is the proximal anterior medial. Your working portal, the second anterolateral, that's this way. You use also the soft spot portal after putting some liquid inside and trying to find, and in the first cases, if you do an epicondylitis or something like that, where is this portal, just to then use for another surgery. You can put the scope in this portal, but sometimes it's a very small zone, so you use 2 portals in the posterior zone, and you need small scopes also, 2.5, just for some osteochondritis and small elbows. You must know specific portals, just like for removing of an olecranon spar, if you like to have some fun, because you can do open. Maintain visualization of instruments and articular surface, always. You know normal anatomy, that you record in the first cases. The normal anatomy, just to remember when you enter an synovial tissue. The normal posterior anatomy also. And you can do some cadaver before you do more surgeries, just to see what's going on around and the nerves and the normal structures and the gut hairs. This is posterior anatomy, antipolecranon, and lateral gutters normal. Use retractors to improve visualization and protect vital structures. Above the inferior aspect of the anterolateral capsule, the radial nerve, that we have seen. If you can go to the cadaver and just to see where are the nerves, but you don't need to go to see the nerves in the surgery, but you must know where are. Avoid the posterior medial gutter when possible. Or if you need to do something, you must consider just to see what is the ulnar nerve before you continue. And plan your surgery sequence as Dr. Sawa today has shown. Just first, second, third in the new surgeries. For me, the surgery sequence is anterior first, then posterior, then the gutters. In the anterior, if you have some loose bodies, just remove at the end, because if not, you must lose some fluid. Do your synovectomy, then remove coronoid osteophyte, and then remove distal humeral osteophyte, and then capsular release or removal. Then go to posterior, elevate the triceps. If scared down, debride and borrow the olecranon fossa, reset olecranon osteophyte, consider ulnohumeral arthroplasty at the end. And the gutters, use retractors, clear loose bodies, careful removal of osteophytes, and capsular release if you consider. Capsular release tips. Direct vision, use elevator, face instruments toward bone, no suction. And release a numeral side of joint, do at end of the procedure, because you will have some extravasation. Release versus resection, so we will see in the future what we have to do. Special care at anterolateral posterior medial elbow. Distension may reduce nerve to portal distance, but not nerve to capsule distance. And the fractures wait 5-7 days. Just Dr. Sabal say 3 days to avoid extravasation. And that's all. Thank you very much.